Okay, let's rock and roll. I'm Dustin, one of the EM residents. Today I have the honor and the privilege of speaking to you about PE in cancer patients. And I think at the end of this as well, Dr. Sabakovats is going to give us or might give us a quick update too on some PERT Team updates. So just before we get started, some people just to say thank you to. So Dr. Surya Narayan's a local thrombosis expert whose help was invaluable in making this talk. Dr. Esau used to work here in Calgary and is now an expat in Edmonton. And then, of course, Philip Boylard and Drs. Fedwick, Lang, and Sabakovats. So today we'll talk about rule out, post-diagnosis risk stratification, changes in treatment, subsegmental and incidental PEs and what we do with those. What evidence do we know about thrombolysis in cancer patients with PE, and then cost considerations and local follow-up. So we'll start by saying that symptomatic or incidental PE, unfortunately, is a bad prognostic sign in cancer patients. Some of the studies I was looking at, 6-month mortality range anywhere from 37 to 90%. And by virtue of that, it's been challenging to show a mortality benefit when comparing different treatments. And so that's kind of where we're starting from baseline. So ruling out PE, we've got a variety of different clinical decision rules, as well as a variety of different D-dimer more recently. Cancer patients were always included in these studies and these clinical decision rules, and they generally make up about 15% of the patient population, but it's not very often that they're actually studied specifically. And I was able to find a couple of examples. So like all patients where we're considering a probability is, and cancer patients are no different. And we'll start by saying that some of these patients are on or should be on prophylaxis, that their cumulative risk is so high. This is borne on the work primarily by Dr. Khurana, who developed the Khurana score. And this is something that's used in an outpatient setting for patients prior to the induction of chemotherapy to determine what their risk is and whether or not they should be prophylaxed. It's not a super important score from our perspective in the emergency department, but one thing that I think is interesting and is important to highlight is that not all cancers clot equally. You can see that stomach and pancreas cancer are particularly nefarious clotters. And then other ones like testicular cancer, which you're going to see in younger males, which I thought was interesting. And the other considerations is their pre-chemotherapy hematologic profile and their BMI. And when we look at patients in an outpatient setting who are getting CT chest abdo-pelvises for staging, up to 5% of them will have an incidental PE, which I thought was interesting. And so the question, I guess, is for patients who are presenting with symptoms, is that higher? And obviously the answer is yes. And so 10 to 25% of symptomatic patients patients who have symptoms suggestive of PE and require a clinical assessment will end up ultimately having a PE. And so where does that come from? So this is a study looking at the American College of Physicians guideline for what I would say, or would imagine, is probably what most of us use right now for working up a PE in otherwise healthy patients or patients without cancer. Is it 3-tiered wells? You risk stratify them based on that. And if they're low risk, you try to rule them out with PERT. If you can't do that, you use an age-adjusted D-dimer. Intermediate risk is age-adjusted D-dimer, and high risk goes straight to CTPE. Some people might be using obviously a little bit different criteria right now, but this is certainly, in my experience, the most common diagnostic strategy. And in this study, there was a 10% incidence, and 1% of them were missed. Now, some of the challenges that I have with this study is one of the things that they didn't do is they didn't include subsegmental PEs in this study. And obviously there's a lot of interest surrounding what subsegmental PEs mean in healthy patients, but we'll learn later on that subsegmental PEs probably represent a much more real clot burden in cancer patients given their underlying risk. And the other thing is given what we know about the incidence of incidental PEs, I really would be reticent to applying PERT in these patients. Interestingly, when PERT was validated and derived, malignancy was not found to be, in the regression analysis, was not found to be a significant risk factor. However, based on what I've looked at from other stuff, I don't know if that represents their true underlying risk. And so I don't think that I would be applying PERT to these patients in that setting of cancer-associated PE. Now, this was a post-hoc analysis of the ADJUST PE study, which was obviously one of the kind of landmark trials that changed a lot of our practices into using an age-adjusted D-dimer. You can see that 25% of these patients had a PE. Unfortunately, they don't break down what the incidence of PE was in the low to intermediate pretest probability group. But overall, this diagnostic strategy had no failures and reduced the use of diagnostic imaging by about 15%. And so I think that there is an evidence base for us to use this diagnostic strategy in cancer patients. I think the real nuance in this strategy is really being cognizant in that intermediate risk group where things like clinical suspicion of PE could tip them into the high risk group where you should more appropriately be going directly to CTPE. And that was kind of echoed in talking with Dr. Surya Narayan and Isa. Their thoughts were that the pretest probability in these patients is so high that you're almost obliged to get definitive diagnostic imaging to rule it out. And in chatting with staff over the last month or so, asking them kind of what their approach was specifically in cancer patients, I found it was kind of split maybe 50-50 between docs who would use a D-dimer to try to risk stratify them into a very low risk group, provided that their pretest probability was sufficiently low, versus those who would say, yeah, you know what, the D-dimer is most likely going to be positive, which it most generally will be, and going straight to advanced diagnostic imaging. So the next question, I guess, is, I've diagnosed a symptomatic PE in this patient, and can they go home, and where do they need to be treated? I think there's two considerations in this. Anytime we're starting somebody on anticoagulation for this, is what's their risk of bleeding? We know generally that the risk of bleeding is highest in the first month, and probably even more so in the first week. And then what's their risk of deterioration or death from this? And there's only really been two studies that have looked specifically in cancer patients. This is the Wright score. It's a McGinn level 3 clinical prediction rule. So it means it's been validated in one narrow prospective sample and it's not ready for prime time. But I think it's just important to highlight the things that are included in that score, which probably is in the back of your mind when you're generating kind of a bleeding risk assessment based on your gestalt, right? Do they have bad kidneys? Are they elderly? Have they had recent major bleeding, etc.? Now, from the perspective of death at 30 days, the POMC score is the only score that's been specifically looking at the 30-day mortality in cancer patients. Again, it's McGinn level 3, meaning that it's been validated in a narrow prospective setting. However, this one is a little bit more broadly validated. It was done in 22 US emergency departments, and it had a sensitivity of 95% and a specificity of 25% for predicting 30-day mortality. Now, we've got the PERT Team algorithm, which has been rolled out. And one of the first things that we do is we look at their SPESI score. Now, the SPESI is a McGinn level 2, meaning that it's been broadly prospectively validated in a number of different clinical settings with a number in multiple different countries with different disease prevalences and disease severity. As mentioned, cancer patients are always included in these PE studies. They generally make up about 15% of the patient population. And there was a post hoc kind of systematic review that looked at all of these different risk stratification tools. And they found that specifically in cancer patients, it had basically a sensitivity and specificity almost the exact same as the POMC score. In chatting with the thrombosis experts, one of the things that they kind of highlighted was that, yes, these patients are high risk, but not all of them need to be admitted to hospital for treatment. I think it's important to remember that these patients are already so highly medicalized over the course of their cancer treatment, whether that's related to their follow-up at Tom Baker, their chemotherapy appointments, their curative and palliative surgeries, as well as the hematologic and the infectious, the metabolic and the mechanical complications of cancer. That I think that in this setting, a shared decision-making model is really important. And so that's kind of what I would advocate for these patients. I think we use our gestalt as we always do, and I think time and time again it's been proven to be a very good predictor, I guess, if you'll say. And then SPESI is probably fine. It's good, we're familiar with it. And I think it can really help with the shared decision making for a patient who's kind of borderline, who you're not totally sure whether or not they should be admitted. You can use that score to look at their mortality and have an honest discussion with them about what their values are. And then, of course, the other considerations that are going to be added into your internal decision making is what their ECOG performance status is, their reliability, what kind of home supports that they have in case they do, in fact, deteriorate from both bleeding and from worsening right heart failure. Now, getting into treatment, and this is where things have also started to change, and some new medications have started to creep onto the guidelines, specifically edoxaban and rivaroxaban. And so what do we know about them? Well, in 2003, there was the CLOT trial, which was kind of the landmark trial comparing dalteparin 200 units per kilogram for a month, and then 150 per kilogram thereafter compared to VKA or warfarin. And in that study, it was found to be non-inferior. And subsequent to that, there's been multiple studies of both dalteparin and tinzaparin. And overall, there's been found that you have statistically significantly reduced recurrence without any increase in major bleeding. Now, we use tinzaparin here locally. There's a couple less studies compared to dalteparin, but overall, the general consensus is that they are equally efficacious and have similar outcomes. In this same meta-analysis, there was the comparison of DOAC to low molecular weight heparin. Now, there was only 2 studies involved in this meta-analysis. One comparing edoxaban to dalteparin, and these were being treated in patients with symptomatic VTE, and then rivaroxaban to dalteparin. And what they found was there is a reduced recurrence in the DOAC group. However, there was a pretty significant increase in major bleeding. Major bleeding is obviously 2 units of PAC cells or requiring some kind of surgical or endoscopic intervention. And the major bleeding in these groups was driven primarily by GI malignancy in the DOAC group. Now, we had a really great session a few weeks ago with Dr. Wang it was a critical appraisal session talking about meta-analyses and systematic reviews. And one of the adages that came up frequently was with respect to meta-analyses is trying to kind of fit a square peg into a round hole, and doing a meta-analysis when the data might not be necessarily robust enough or homogeneous enough to actually make inferences that bring us closer to the truth. And that could make an argument that might be the case here. So the 2 studies, Hokusai was edoxaban versus dalteparin. It was an open label non-inferiority trial, and it was industry sponsored. And they used kind of these weird non-validated bleeding scores. The SELECT-D trial was an open label pilot study, and they changed the design of the study halfway through to exclude the enrollment of GI malignancies, which probably decreased their rates of major bleeding, and hence the challenges in interpreting the meta-analysis data. However, despite that, edoxaban and rivaroxaban have come on to, for instance, the European Society of Cardiology guidelines as reasonable treatment options for VTE and PE in cancer patients. Now, subsequent to that, just recently, just touch on the Hokusai data again quickly. So these are the Kaplan-Meier curves of the Hokusai data. And so on the left, you see the patients with major bleeding over time. And what you can see is that from day 0, there is a difference in the effect of harm, which is what we expect when there is a true treatment or harm effect. Conversely, when you look on the right from the perspective of recurrent VTE, you see that for the first 30 days, there is 0 difference in the recurrence. And you see maybe a little bit of change, but really there's no difference up to 60, 90 days. And so why is that? Well, first of all, the treatment protocols for dalteparin remember that there's the dose decrease at 30 days. The thought is that after you make it through the first 30 days, your risk of recurrence is lower, and as a result of that, we can decrease the dosing of dalteparin. And then beyond 60 and 90 days, there's probably a degree of non-compliance that's not captured or not controlled for in the data. We know that patients are much less likely to be compliant with the parenteral or subcutaneous treatment. They're much more likely to be non-compliant, and so that's probably contributing to that as well. Now, just recently, there's been 2 trials that came out over the last month or 2 looking at apixaban versus low molecular weight heparin. These were patients with both incidental and symptomatic VTE, and they found pretty incredible results. When you look at the recurrence in the apixaban group, 0.7%, like, wow, why aren't we prescribing apixaban to everybody? And then from the major bleeding perspective, 0% major bleeding. Now, anytime I see a 0% in a study, I start to get nervous and wonder whether or not these results are going to be reproducible and whether they're generalizable, or there's something inherent to the patient population that suggests that that won't be the case. And when we look at major bleeding rates of 0%, cancer patients on placebo bleed at a higher rate than 0%. And alternatively, from the perspective of recurrence, when we see non-cancer patients, their recurrence is higher than this. And so again, there's something to suggest that this data or the patient population will not be generalizable and reproducible. Now, this was a trial that came out 2 weeks ago, the Caravaggio trial, which was a multi-center, multinational, about 1,500 patients, again, looking at symptomatic and incidental VTE in cancer patients. And what they found was a statistically significant reduction in the recurrence without any increase in major bleeding. Now, this trial did include patients with GI malignancies, but they were pretty low numbers and weren't really well represented. And when you look at the Kaplan-Meier curves of this one from the perspective of recurrence, it diverges at 30 days, which is where we just briefly talked about the dose reduction in dalteparin. And so perhaps we're just, the increased recurrence in the dalteparin group is just by virtue of underdosing them. One of the things that comes up with respect to DOACs is they interact with many of the medications that are used, both the chemotherapeutics as well as medications used for symptom management, altering, either inducing or inhibiting the CYP3A4 enzyme. And so that's one of the challenges as well in prescribing the DOAC medications. And so the guidance from Thrombolysis is to, as it stands right now, to continue starting these patients on low molecular weight heparin and allow anticoagulation changes to be made by the oncologist in the future. It would be very challenging if we started a patient on a DOAC in the emergency department and then trying to convince a patient that, you know, there's a lot of medication interactions and you actually need to do a subcutaneous injection every day. However, I suspect that we'll probably start to see more and more patients being prescribed on these, and so certainly I think that's something that we will start to see for patients coming in who have had previous VTE who are on DOACs. There's some moderate heterogeneity between low molecular weight heparins and DOACs for mortality. Again, with respect to the meta-analyses, I was unable to find, or as far as I could tell, there's never been any proven mortality benefit when comparing low molecular weight heparins to DOACs to warfarin. There's been trends either way, but I was unable to track any studies down that were able to show that, and the meta-analyses did not. In selecting a DOAC patient, again, I think that this decision is probably more nuanced than would be expected of us in the emergency department. The algorithm that's suggested and what our thrombosis and oncology colleagues would go through is obviously a bleeding risk assessment, which we can do as well, but specifically things like thrombocytopenia and renal impairment and recent bleeding would put them in the higher risk group. The type of cancer, GI and urothelial tumors, represented the overwhelming majority of the major bleeding in these patients. And then obviously in the drug-drug interactions is probably the big one that is out of the purview of what would be expected of us in the ED. Other nuances, apixaban and rivaroxaban are more susceptible to drug interactions. They've got variable study designs with different exclusion criteria. Very few patients were on the checkpoint inhibitors that Megan gave us a great talk on a few weeks ago. So there's still clinical equipoise with respect to the DOACs, and head-to-head trials between those two are needed. There's a variety or a number of further RCTs that are currently enrolling, but the majority of them are looking at dalteparin and rivaroxaban as opposed to head-to-head trials with DOACs. We're treating indefinitely until cure, generally a minimum of 6 months. This isn't so important for us. And these are the regimens, so that it's tinzaparin 175 units subcu daily, which is what these patients are going to be prescribed, or what we should be prescribing in the ED, obviously, in the absence of any history of heparin-induced thrombocytopenia or anything like that. Now, what do we do with subsegmental and incidental PEs? Well, obviously, the topic of subsegmental PE is a very interesting one in patients without cancer. Obviously, there's been studies to show that there might not be any treatment benefit to treating subsegmental PEs in otherwise healthy patients who do not have a proven DVT. Secondarily, there's also the challenges with respect to the inter-observer agreement or kappa values between radiologists as to what represents a true clot and the false positives on CT scan. But it's probably a different story in cancer patients. When we look at these patients, patients with subsegmental or incidental PEs had pretty much the same recurrence as cancer patients with more proximal clot. And so the guidance from Dr. Suryanarayan here is to treat it all. Subsegmental, these patients are much more likely to represent true clot, and for all intents and purposes, they have a permanent, persistent risk factor, provided that their cancer has not been cured, to be thrombogenic. Dr. Esau in Edmonton takes a little bit more of a nuanced approach and asks, we'll call radiology and say, what's your confidence in this representing a true clot? And I think that approach has real value in patients with high bleeding risk, right? If they have intracranial metastases, or they've got severe thrombocytopenia or something to that effect where they have a high bleeding risk. And so in those patients, I think it would be reasonable to take the approach of Dr. Esau as well, and then talk to somebody like Dr. Suryanarayan, such that we've gathered more information about what this patient's bleeding risk is before making the decision to anticoagulate them. Now, thrombolysis, there's not a ton of information about thrombolysis in these patients. This is one of the only real studies that I could find, and it was basically just a retrospective analysis of about 70,000 admissions for PE. Again, about 15% of them had cancer. But one of the more interesting aspects of this was that of the cancer patients who were admitted to hospital, who received TPA, there was no difference in in-hospital mortality compared to non-cancer patients. And I thought that was, certainly very interesting. And further to that, when I was looking at studies with respect to quantifying and determining risk factors for major bleeding in patients who receive TPA for a PE, cancer was not found to be a statistically significant risk factor, which I also thought was interesting. Biologically, it doesn't make a ton of sense to me. However, that has not been borne out in the literature. And so I guess for the perspective of submassive PE, I think that you can forget about it. I think that the benefits are nuanced enough that these patients are not going to be considered for it. But for a patient with a massive PE who's got vasopressor dependent shock, I guess one of the first questions that I would want to have is, do they have known intracranial metastases? And trying to do a bleeding risk, are they thrombocytopenic, et cetera. And then the other big question that I would have, and depending on the time of day, would be to try to get a hold of their primary oncologist and say, hey, what's the status of this patient's cancer? Are they palliative? Do we have real curative intent here? Are they expected to live for another 4 to 5 years? And that coupled with a good ECOG status, I think that based on the evidence here, that maybe we should be giving it a college try in consultation with the PERT team. Cost considerations. So tinzaparin's super expensive. Alberta Blue Cross, if they have it, it's still about $150 to $200 a month. It's obviously weight-based dosing. However, there is access to compassionate use via oncology, so the patient can get access through doctors like Dr. Surya Narayan. Warfarin's pennies on the dollar, and Pixaban with Alberta Blue Cross is about $22 a month. And then finally, just wrapping up, local resources. So the Cancer-Associated Thrombosis Clinic is where these patients should be referred to, and they'll see Dr. Surya Narayan and her colleagues for their ongoing management and care. And as I mentioned, more nuanced decisions with respect to the initiation of DOACs or whether they should be continued on low molecular weight heparin by and large. And finally, I don't know how often, I asked a couple staff this over the last few weeks as to whether or not this ever happens. If you guys would ever get a rapid call from a family doctor saying, hey, like this patient of mine got an outpatient CT chest and they were found to have a PE. Can I send them to you as a referral? And so I guess this would be, in the absence of them having symptoms, this would be an incidental pulmonary embolism. There's actually a pharmacy. This was a program developed by Dr. Esau and Adrian Azim. It's open 24 hours, although their hours might be a little bit reduced right now with COVID going on. But it's generally open 24 hours a day. And this pharmacy will see patients with incidental PEs, start them on low molecular weight heparin. They'll actually order the blood work, the follow-up blood work, to make sure these patients don't develop HIT, and then they can be referred on to Tom Baker or follow up with their primary oncologist. So takeaways, I guess, for me are the two-tiered wells with an age-adjusted D-dimer has evidence to support you. Most of these patients are going to require advanced diagnostic imaging, but if you do use that treatment algorithm with a very sober assessment of patients who are in the intermediate risk group to ensure that they're not actually high risk, you can reduce your use of advanced diagnostic imaging. From the perspective of disposition, I think gestalt added on with SPESI for patients who are borderline and you're not really sure, such that you can have a good shared decision-making model with these patients given their high contact with the medical system. And then from a treatment perspective, low molecular weight heparin for now is still the gold standard, but we'll probably start seeing patients on DOACs in the future, although not necessarily all of them. And then treat all clot, unless the patient has a really, really high bleeding risk. Then I think, having the nuanced approach and talking with a hematologist or their primary oncologist regarding what it should be if it's just a subsegmental pulmonary embolism, and then refer these patients on to the CAT clinic for follow-up. So those are my references, and then we can take some questions. And I know Dr. Savakovats, if he's here, I think he was wanting to also chat up for 5 minutes about or a couple minutes about the PERT team. So we got 2 questions, so maybe I can do that. Jason asks, are they all equal with respect to their interactions? So apixaban and rivaroxaban, apixaban and rivaroxaban have a higher predisposition to interactions compared to edoxaban. Now, all things considered right now, I think that apixaban probably has the best evidence base for it. One really good study compared to edoxaban and rivaroxaban. But yeah, edoxaban has the least amount of interactions, but it also had the highest rate of major bleeding. What else was I going to say about that? Some be preferred. And so from the perspective of whether or not some would be preferred, I think that because we don't have head-to-head DOAC trials right now, and the enrollment and exclusion criteria of the low molecular weight heparin versus either apixaban, edoxaban, or rivaroxaban had varying different inclusion and exclusion criteria. That is challenging to say, and I think that's one of the challenges for Dr. Suryanarayan is going through that data to decide which DOAC is best for which patient because of the differences in the studies. Will it change prescribing patterns? I really think apixaban's probably irrespective of cancer. I think apixaban's probably, in my mind, been shown to be the best, although I might be wrong on that. And so I think certainly as the more evidence comes out, my intuition based on the evidence that we've seen so far is apixaban will probably end up being the one that takes the cake. But again, we need clinical or head-to-head trials between the different DOACs, so there's still equipoise between whether or not those medications are better than one another. And then from the barrier for tinzaparin use, it's just administration, the sub-Q injection, and the challenges with that, and I guess the unpleasant need, as you mentioned. And then us short shoppers is not having a 24-hour location.